Medical Society. Marissa, we thank you for being here to support Dr. Formoso and our guest speaker today. Dr. Ferdinand Formoso has such a good name and reputation throughout the community. He is an interventional pain specialist and is president of the Duval County Medical Society. He has over 23 years of experience. So he's going to talk with us today about some of the challenges that independent practices face today and how collaboration through the medical society can provide solutions and support. And so everybody in the room that is a member and out in the links that is attending virtually, they know that while we love hospitals and we love hospitalists and we work with large MSOs and medical of all types of shapes and sizes, we are very passionate about keeping the independent physician in practice because it is harder and harder for them to make a living and remain competitive in today's environment. So we really appreciate you coming out to share some of the strategies and support that are out there to help us accomplish our mission. So thank you very much.
I appreciate that introduction, Connie. Thank you for the invitation to speak. This is a topic that is very near and dear to my heart because as you said, I know many of the physicians. The trend is to move into group practice and more so hospital employed practice. I'm a staunch supporter of private practice, and I'm fighting the fight, and hopefully we will maybe be able to take the profession back. I'm keeping my fingers crossed. I don't know if that can happen, but essentially that's the purpose of this lecture, is to discuss private practice, some of the challenges, and Joey is present and my wife Elisa is here. They were with me when we started our most recent practice, and the struggles that we went through and some of the challenges I'll kind of list here in fairly quick format. Thank you for the introduction. My name is Dr. Formoso. I'm the current president of Duval County Medical Society. And Marissa, thank you for being here. And it's been a real honor to be elected the president. It's probably one of the biggest honors that I've had in my life. I did not see it coming. If anyone had asked me in medical school, someday would you be the president of the medical society in the city that you work in, I would have never guessed that. So I'm honored to do that. Thank you. A little bit about myself. The font keeps getting smaller because I keep adding stuff over the years. But I grew up in Western New York, in Rochester, New York, went to college in Buffalo, at University of Buffalo. My undergraduate degree is actually in psychology, which is interesting to kind of segue from that into medicine, which it is working well in my field that I'm in currently. I've had my doctorate degree at New York College of Osteopathic Medicine. At that time, I, in my heart, believed that I wanted to be a general surgeon or a surgeon of some sort, and still have, people tell me, good hands. And at the time, my professors would not accept me doing anything but a surgical training. And actually, the chief of the department at St. Barnabas literally swept me into their program, even though I initially had wanted to do physical medicine rehab, but they wouldn't stand for it. They're like, your hands are too good to do PM&R. You need to do surgery. So I did that, and it was a great experience, a wonderful experience, but quickly learned that lifestyle was not for me. And my wife is happy that I didn't do that because I'd be on call every other night. And so I ended up switching back into physical medicine rehabilitation and was accepted back into the Temple University program, where I was chief resident at Temple, and then went into the fellowship program there at Temple University, completed my interventional pain medicine fellowship at the time under the program director, Dr. Falco, who was the president of the American Society of Interventional Pain Physicians. So it was a real honor to learn under him. After finishing the fellowship, I moved to Jacksonville and was employed for a year And after that 1 year, founded the Coastal Spine and Pain Center and grew that practice to become a very large multi-center location with many physicians and advanced practice providers. And as that practice grew, it became more corporate in nature, and my partners and I had different viewpoints on how we wanted the practice to operate. And about 2 years ago, I sold my shares in that practice and now formed my own practice, which very apropos name, Formoso Spine and Pain Joint Specialists. And we've been in that for the last 2 years, and things are finally stabilizing, and the practice is doing great under the leadership of Joey. And I can't thank you enough for everything that you've done to help the practice. And so I'm going to talk a bit about what it means to take that leap and go into private practice. Some of these statistics, when you look at them, are pretty sobering. You know, this was the last data that was available. Just shy of 47% of physicians currently are working in a private practice setting. You know, a generation ago or 2 generations ago, this number was very different. 80, 90%. That was the norm. You know, I remember growing up, going to the doctor's office. You'd go to the little doctor's office, you go see your doctor, and it was a very personal experience. That's the way it was. That's what I remember. Probably many of us in this room remember it that way. It's very different now. You know, and then if you dial in that number even further, 44% are actually self-employed. Then what is even more shocking is when you look at the younger physicians, the number is down to under 32%. So we are becoming an endangered species. And I say that when I give these lectures. The private practice doctor is disappearing. You can see the trend just from 2012 to 2022 went from 60% to under 47%. So that's not that long ago. Why is it? You know, we saw it when we started our practice. Probably the number one thing is payment. You know, we are being financially squeezed every day, and we're just looking at the numbers. You know, 2024 Medicare rate drop again. You know, what other profession do we know that in real dollars over the course of a decade or two, literally seeing real dollar decreases over the course of 10 to 20 years? I can't look at my plumber and say that. I certainly can't look at my electrician and say that. I can't say that about buying a car. I mean, can you imagine if you went to GM and told them, well, you're going to make 20% less on your car sale in 2024 than you did in 2004? Do you think that that profession, that industry would accept that? Absolutely not. But we are, apparently. The biggest issue is payer contracting. You know, when you are, again, as the data from the slide before, when you are becoming an extinct or extincting species and our numbers are smaller, we can't negotiate. And we were just talking about that earlier today before the lecture, of fighting with Blue Cross and United and trying to have them look at us as an entity of value. And they don't, because we're 6 clinicians in my practice compared to, you know, Baptist, who has hundreds. You know, so how can we compete in that setting? We're subjected to payer audits. We go through these all the time. Our practice, which is on the razor's edge of profitability, can't handle these audits, and God forbid we had to pay back, you know, for overbilling or whatnot. That would be catastrophic. You know, as I said earlier, declining reimbursements are just always there. Medicare fee schedule keeps going down. How can we survive these constant decreases in reimbursement? Prior authorization now is an issue, and especially in our world, you know, I'm a procedure-based physician. You know, we are are mandated to get authorization for procedures prior to doing them, but that doesn't guarantee that we actually get paid. So they may tell us and give us this false, cool comfort of having authorization for a procedure, but we may not get paid anyway. And that creates issues with accounts receivable and then retroactive denials and all sorts of financial issues that we feel on a day-to-day basis in practice. And like I said, when you're a private practice and barely making it, these things have huge consequences on whether or not you can survive. From a logistical standpoint, let's say that you want to leave a hospital system and form your own practice. It just takes an incredible amount of work just to have consent forms and business forms and all, just the infrastructure of the practice that each time I've formed my practices, it's sort of somewhat reinventing the wheel. And you realize like how much it really takes to get a practice off the ground. And that goes to billing infrastructure. You have to have your EMR in place and the IT support that goes along with it. And nowadays you can't afford to have IT people in-house, so you have to rely on outsourcing that, which then, like it says there, the lack of support is there because they're dealing with many clients and you're one of many. This past year or two, the rising cost of supplies has just gone through the roof. We've seen prices of lidocaine and marcaine double, triple, if you can even get it because of supply chain shortages. And there was a time at which I was kind of laughing at myself. I'm like, I try to go into private practice. You're fighting all these issues, financial issues, infrastructure issues. I'm thinking to myself, and I can't even get lidocaine. Like, what has this world come to that literally a physician's office can't get the most basic of basic anesthetics? We couldn't even get it. I mean, Joey can tell. We literally couldn't get it at any price. What is the world coming to is what I was thinking. And it seems like that has improved at this point, but it's just frustrating, is to say the least. And then when you're a small practice, I put on the base there, the marketing is a real thing, especially as a specialist, and we have to try to get referrals from primary care doctors and other sources. So that costs money and time. Staffing has been a huge problem. That seems to be getting a bit better over the last 6 months, but prior to the last 6 months, it was very difficult just from a general staff perspective. And I mean medical assistants, front desk office, just basic fulfillment of just base employees that you need day to day. And that's not to speak of physician recruitment and how difficult it is to lure a physician into a small practice. Physicians are leery now of small practice because they don't know how financially strong you are. Can we pay the money that a hospital could pay? It makes it very difficult for us in that small practice setting. And then when you spin the physician burnout into the equation, doctors just want it kind of easy. And it's hard to get them to understand that, hey, this is private practice. It's not easy. But there are great things that come from that. From that challenge, being in private practice is wonderful, but it doesn't come for free. But a lot of these young guys and gals don't understand that. And I don't know that they want to. That's the other question. So why would you go into private practice? That's me some days. And what seems to be the problem, Mrs. Johnson, she says, I feel the way you look. So sometimes we feel this way in private practice. And it's not all doom and gloom. It is wonderful to be independent, and I don't want to necessarily be a Debbie Downer that it's all doom and gloom. There are great things about having the ability to treat a patient the way that you want to do it and not the way some accountant in an office that you don't know wants you to do it, or see a certain number of patients because the balance sheet tells you that you have to do it a certain way. You know, that's where I feel that medicine is dying in a way, because we didn't worry about those things a generation or 2 generations ago. Now it has become a business just like any other business, and that's a shame. You know, I feel like we've lost the magic of medicine in a way because of that. This spins into this physician burnout conversation. Some of it came because of COVID, some of it because of the issues that I just laid out there. It's very difficult to practice these days. And these numbers tell you everything that you need to know in a nutshell of how doctors feel. This is how physicians feel. You know, we went to, or I did at least, and I believe the generation before me, we went to medical school because of our sense of independence. We have discipline, we have independence, we have the desire to care for people and make hard decisions. That's part of why you want to be a physician. You don't go into medical school, or at least I didn't, and my predecessors didn't go into medical school to become an assembly line employee. We didn't do that. Why would you go through all of that work and do the beautiful, magical things that we did and learn in medical school to care for patients, to do things that other people couldn't do? Why would we go through all that just to be told by a finance person how to do it? That makes no sense whatsoever. No sense. And this is why, when you ask physicians, would they choose to become a doctor again? Barely more than half would say that they would. Because at the core, medicine is not giving us what we wanted from medicine. We didn't want to be told what to do or how to care. We got taught how to care for patients, and it's a God-given and trusted skill that we feel is our right to give to the patient, not a businessman telling us how to do it. And until that core situation gets dealt with, these numbers are not going to get better, I don't think. And my fear is that the best and brightest will not go into medicine knowing what is coming at the other end. That's my fear. So what are solutions? And this is kind of a joke, you know. Get a pizza shop, right? And I know it seems funny, but here I stand, and I am actually the master franchisee for Salvatore's Old Fashioned Pizza, and it is not a joke. And I've not to say that I'm going to quit medicine, but I'm looking at other options. I've become involved in real estate acquisitions, and now looking into, you know, restaurant options, and I'm hopeful that this works out, and I'm not sure what the future will hold, but it seems like it could turn out to be a great thing, and in a way that, you know, if medicine doesn't quite go the way I think that it should, or if I can say I will not become a government employee, and if it ever came to that, I would much rather make pizzas than become a government employee. No offense, you know. But joking aside, you know, what are some other solutions? You know, we need to band together. I mean, the system, quote unquote, whether nefarious or otherwise, is doing its darndest to divide doctors. They are putting us into our own silos. They don't want doctors to band together. They would rather have us be employed, not have a say in reimbursement, not have a say at a governmental level. You know, they like us to just kind of go to work, see patients, and don't ask any questions. If we can group together and band together, whether it's individual practices working in, you know, different ways in a legal manner to kind of band together, that would be wonderful, or other physicians that are willing to group together and form larger groups. At the end of the day, it's better to have physician-owned large practices, and that way our voices and our needs as doctors can be heard and listened to. I feel, and I think many physicians that I speak to feel the same way, we need to reverse this trend of physician-employee. If not done, the face of medicine will be changed forever and cannot be changed back. The second half of this lecture is going to talk about medical society and why societies are so important and the power of collective voices. That ties into this banding together. The more that we can collaborate with each other, Marissa can say, when we have our group meetings, it's wonderful that we network and we can talk about challenges that we have and, well, how can we work together and deal with these challenges? Without societies, we absolutely are splintered in the community. So as the president of the Duval County Medical Society, I'll give you a little bit of a history here. The society started in 1853. It was a handful of physicians at that time in a relatively small town. And at that time, smallpox and dengue fever, malaria was a big issue. And there was a huge outbreak at that time. And the citizens of Northeast Florida were under great distress from medical issues. And doctors at that time formed the Duval Medical Society in an office actually at the corner of Bay and Market Streets. This was the first, and most people don't know this, the first medical society in the state of Florida. So here in Duval, in Jacksonville, we have the oldest medical society in the state. There was not an organized medical society for another 20 years after we formed. And we, the Duval County Medical Society, was instrumental and actually formed what we now know as the Florida Medical Association. And it was here in Jacksonville. And that was formed in 1874. So we formed in 1853. 21 years later, the Florida Medical Association was born. We currently, with all that history, still continue to be the largest medical society in the state. So as a singular medical society, we have nearly 2,000 members, which is fantastic. And we're always looking to grow. The more doctors we can have in the society, I think the more powerful that we become. And the louder our voice can be heard. Why would you want to be a member? Well, it's the networking, like we said. We have nearly monthly membership meetings, which are wonderful. You know, there's dinner and lectures. Depending on the scenario, it could be some of the hospitals coming over and showing the latest technology that they have to offer. We have, which later you'll see, we get the political folks involved. They come and give talks and network. It's really just a great way for us all to get together and learn about the different issues and successes that we have in our practice. And our next meeting is actually scheduled for the 13th of February, and I encourage everyone to register at our website there, dcmsonline.org, to come and join us. There are great other opportunities within the the membership, a couple of the things that we'll highlight here, Women in Medicine is a wonderful group of women physicians that get together. They have Doctors' Day celebrations, volunteer events, different advocacy events that they host. Female legislators get together with the group with question and answer sessions, which is wonderful. You know, one of the other things that we do and have done for a long period of time is the DCMS Navy dinner meeting. We do that annually, and that's been done for decades at this point, where the leaders of the Duval County Medical Society and the leaders of the Navy locally, the naval bases and the Naval Hospital get together and break bread and talk about issues that are important to us. And there's usually a fantastic keynote speaker that typically is representing the military, and that's been an honor to be part of those meetings. This year, I think we're meeting again in April, right? Is it May? So the upcoming meeting will be in May of this year. So these are some of the fun things that we do, more so resident-oriented. We do a Jaguars tailgate party annually, which is a really nice event. We do what's called Beers with Peers. That's quarterly. It's a meeting between the attending physician members and residents in the area. You know, this is a great opportunity for, you know, the elder folks to teach the residents what to expect when they go out into practice. And so it's just a great way for us to interact with the residents. And in that light, we have an annual Life After Residency and Fellowship Seminar that goes through that, and an annual poster symposium. And our meeting annually also brings all of these people together once a year, which is great. We have a number of different committees that members can be part of. I encourage, get involved. You know, we got the get involved button there. Like, we need people to be willing to volunteer and get involved in these committees. As the president of the society, I can place anyone that is interested in a committee. I welcome anyone to contact me or Marissa or the society, and we'd love to get you involved. One of the big things that we do as the Duval County Medical Society is getting involved in political advocacy. And that's a group of us a couple years ago and we do go every year. We make our pilgrimage to Tallahassee, typically in December, and we explain to the legislators, direct, you know, face-to-face meetings. Typically, our group meets with our local legislators, and we explain to them things that are important to us. And in conjunction with and in concert with the Florida Medical Association, we make these efforts, and it takes time. You have to meet with these folks. They know about us as doctors, but we're kind of way outside of their reality. For many years, there has literally been one physician in both houses of government, in the House of Representatives and the Senate, one physician. So they don't really have interaction with physicians to understand our issues and how to vote on some of these bills. They don't know unless we go and talk to them. So in 2023, our efforts resulted in additional residency training program funding, loan forgiveness for physicians that decide to practice in underserved areas. We've fought and won, which was a huge fight, to increase Medicaid reimbursement to Medicare levels for any Medicaid patient that's under the age of 18, which was a huge change in the delivery of care for pediatrics. You know, pediatric patients had very few options before this. They would have to go to Shands or, you know, a Shands subsidiary office. Now, with that effort that we made and the change that happened at government level, a pediatric patient that has Medicaid can go anywhere that they want. What a change in the way healthcare is now delivered for those folks. You can't even put a price tag on that. The residency program bullet point, I'll expand on that. We had lots of conversation with the legislators, and it's wonderful. We're opening up some medical schools, and we actually have a new medical school that's going to be associated with Jacksonville University opening here in a year or two, which is fantastic, and it's great to create doctors through medical school programs. But if you look at the data, what we find is that although it's wonderful to form and create doctors, it's more important to have residency programs available for those doctors. And why is that? Because that's where they stay. It's an overwhelming statistic. It's 60-70% or so of the physicians stay where they do their residency. And if we are in a looming physician shortage in Florida, which it seems like that is going to be the case, we need to figure out how to keep doctors in the state. And through those conversations, the folks in the House and the Senate that we spoke to really heard us and allocated about $30 million to residency programs in the state of Florida, which is huge. And that's again on our docket for this year. So we had some efforts this year, including what I just said with residency program funding. ID card and dispute resolution was a huge part of what we spoke to this year. What does this mean? Well, most patients don't realize that there is a dispute resolution system, that if there's an issue with your health insurance not paying a bill, or if there's a question, the state has an office dedicated to that. How many people know that? Almost zero. Almost zero. There's no, that they don't, I don't know if they don't want that information to be out there. I'm not sure what the motivation is. So we went to Tallahassee and said, look, we need to have transparency about this. On every Florida issued insurance card, we designed and created a QR code that you scan the QR code, and guess where that takes you? Right to the state government dispute page. Very simple, but at least the system will be transparent, and patients and physicians will know that that's available. A simple thing that seems simple, but it can have huge impact. Prior authorization reform, I talked about that earlier. We are given cool comfort, that we have prior authorization for procedure. What does that really mean? If the insurer can basically say, well, yeah, we gave you prior auth, but we're not paying you anyway. What value does it have to do this whole process of getting prior authorization, have all the staff that we have to hire to do it? Why are we doing this? We need to have that prior authorization actually have teeth. So we have brought this up, and the legislators understand and are working on at least having some system. And in our world, our perfect scenario, which we fought for, would be to literally have that prior authorization be a binding contract, which is what it should be. If it is not binding, why do we bother doing it in the first place? Workers' compensation medical reimbursement is among the lowest in the nation. The surgical reimbursement is decent. It's probably average. But on the office side is low, very good bit below average. So we're looking to hopefully bring that compensation level to more norm, what would be the norm nationally. We're fighting for what's called a copay accumulator. People may not, I don't know if any of you know what this means. This is another ploy by the insurance companies. Has anybody ever gone to the doctor and they give you a copay card to pay like less copay on something? Yes? Well, right now, you may think that you're paying down your deductible with using that card. You're not. at the end of that 6 months or whatever time frame that that card is good for, you may think, well, I've been getting that medicine for 6 months, so my deductible's got to be lower and I should be out of that big copay. They don't count any of that because they consider that charity. Why? Why is it not counted? Why does it matter where the funds are coming from? The insurer is getting the funds. It's not like we're asking them to eat the funds. They're getting the funds, but they don't want to count it because it didn't come from you. That's not fair. And we're fighting to make sure that that does count. We, again, had budget the loan forgiveness, the GME funding that I spoke to earlier. We're always fighting for that. We now this year are fighting to get Medicaid to Medicare parity for all beneficiaries. Like I said, as it changed the face of care for pediatrics, it could do the same for adults. And theoretically could drive the cost actually down. Right now, if you have Medicaid, your choices, your healthcare choices are so limited, you may not treat your blood pressure because you can't find anybody to take your insurance or your diabetes or other general, medical issues, which then result in those people going to the emergency department and getting admitted to the hospital, which costs orders of magnitude more than it would cost the state to pay for an office visit. One ER visit would pay for years of primary care visits. One. And this is what we're explaining to the legislators, and I think they see the numbers, they're believing it, and we are hoping that that will go through, which I think would be amazing for healthcare in the state. We were fighting to kind of clean up this, the consent for minors. There was a parental bill of rights that came out in 2023, which made it very difficult for pediatric patients to obtain healthcare procedures, particularly because as the law is written right now, the parent physically has to be there in order to provide consent. And there's concern that maybe, let's say an add-on surgical procedure may have to happen, and if the parent physically isn't there, that child may not get treatment that they need. So we're working on kind of cleaning up that verbiage so it's a little less difficult for these treatments to be completed. If you are a member, you will get weekly updates because we have our team, or Fraser's there regularly, or we have a lobbyist that's there on our behalf as well. So you will get weekly updates on all of these things that we're talking about and things that weren't on our radar that could be coming up. As part of our political advocacy arm, we have an annual post-legislative session dinner meeting, which is wonderful. Last year, I think all of our local legislators, just about all of them, came and met with us, and that's a picture from our meeting. And it's fantastic. It's a way for our members and the physicians to have a direct one-on-one with our local politicians, which is fantastic. Those of us that go to Tallahassee do that, but that's only a small handful of us. This gives us the opportunity to open that up to the membership at large. And this is always one of the most popular meetings that we have. We had a full house, last year, busting at the seams. And it was really a great forum and had open discussion and debate. It was fantastic. We have a PAC, which is a political action committee. It's called the Northeast Florida Medical PAC. It works in conjunction with the FMA PAC. I'm a board member on the FMA PAC as well as our local Northeast Florida Medical PAC. Is Danny the chair or am I the chair? I can't remember now, but I'm involved in it. And it's a great way for us to be able to raise funds and then have our volunteer leaders work along with FMA to support pro-medicine candidates. You know, it's not a partisan pack. It's or I should say, we are partisan. We are pro-medicine partisan. So as long as we find candidates that are pro-medicine, we want to be there to support them. And the other thing that it gives us this opportunity to have direct one-on-one with folks that are running, because we have learned that the sooner that you can make that connection and that personal relationship, the better it ends up being in the long run, because they know us and they understand what our needs are and our worries are. We need support. You know, the more members we have in DCMS, and I pound the gavel every meeting, you know, give to the PAC, give to the, we have to have funds in order to exercise the voice, so to speak. We have DCMS CME opportunities that are available all the time through the portal. We also offer discounts to CE Broker, which is the electronic brokerage house that handles all the medical hours that we put in. We have member pricing reductions. We also offer the state mandated CME annually. We have an annual meeting that has CME hours incorporated with it. I'm hoping to maybe expand that to have more hours involved. So it's another way to get your CME done, you know, through the society. We also have a foundation called the Duval County Medical Society Foundation. It was formed in 1959 as an arm of the DCMS. The foundation does things that directly impact the community. One of the big programs that we're involved in is called LifeBridge. It's one of the things that we're probably most proud of. Talking about burnout earlier, this is our direct answer to burnout. It's a voluntary and confidential system. It is considered coaching, which is kind of what it says on the bottom there. So it's not health care, so it doesn't result in a medical note. It doesn't result in any paperwork, as physicians are concerned that it could have an effect on their license or their ability to practice if they see a psychiatrist or have, you know, issues that they're afraid to talk about. And this allows the physicians to have an outlet for that and not have the fear of any kind of negative repercussions. Fluvax Jax is one of our huge campaigns that has just been really successful. Again, one of the things that we're very proud of. It's a community-wide campaign that aims to increase flu vaccines all along the First Coast. It was created when the COVID pandemic and the flu season overlapped, and we were concerned about the local hospitals becoming overburdened. So we basically give vaccines to anyone that doesn't have the means to purchase the vaccines or is uninsured. And through those efforts, we've provided, you see that number there, just shy of $140,000 worth of free vaccines in the community, which has been fantastic. So I thank you for your attention. I hope I didn't go too long and too long-winded. That's my email there and our office phone number. Our locations, my practice, I've got locations at the town center, out at the beaches, and a west side location. So we've got 3 offices to serve the community. That QR code that you see there is a way for you to become a member of the DCMS if you so choose, which we would love that, and scan that, and that'll take you right to our application portal on the website.
It's a very good presentation,
I
Dr.
hope you
Formoso.
enjoyed.
Yes, it was excellent. If you don't mind having the opportunity to answer some questions for us.
Sure.
So we had some watch parties going on, and because of scheduling within the office, many of them have had to drop off. But One of the questions that was raised is, we actually have within our membership practices that do traditional insurance, but we also have some that, last year and the year before, the buzz was fee for service, but this year it's really been membership models. And so when I think of those different types of models, I think about the complexities of it, because if I'm, as a consumer, as a patient, if I'm seeking a wellness model, I could see a membership model working very well. But if I had something serious or something that you might treat, I would have to go the insurance route probably. And so I didn't know how that subscriptions, how they were impacting the remaining practices that actually used insurance. Has it created higher insurance costs for the rest of you, or is it lower because the insurance companies are saying, oh, we're losing people by going for fee for service or subscription based?
Right. Well, I don't have a direct answer to say whether it has had an impact on insurance premiums or whatnot. My understanding is, and this is just through speaking with physicians that are doing this, is these membership models are a way to gain access. So it's not necessarily, and this is not every practice, and I'm not saying this, but many of the practices that use this model charge that fee so that you have access, quick access, and more, concierge, let's say, service, and you're not just getting in line to deal with MRI authorizations or medicine authorizations and whatnot, because logistically it's not easy to process all of these orders that we have to process, and we don't have it quite as bad as the primary care doctors do. So my understanding is that having this subscription model allows a primary physician to focus on a smaller population, still be able to create income to live and make a reasonable physician income without having to see just the tremendous volume that you would have to see otherwise. I believe they still place their billing through the insurance company for office visits and actual services. The fee is just for access.
Got it. Okay, very good. And then another question was, because we do work with municipalities, and in fact we're working with one now, and when they sent me the breakdown of population, it mirrored very closely to another municipality that I work with, in that a large portion, because we're Florida, right, a large portion of their population that's on the increase is the over 80 and even special projects for, over 100 years of age, because that's the fastest growing population supposedly in the world, right?
Wow.
As medicine gets better, people can extend their lifespan. So I mention that because we're going to be working with them to help draw medical services that will be appropriate for every age group, but just the serious focus on those demographics in now 2 municipalities is starting to look like a trend when we speak to a few others. I didn't know if you had anything from the medical society that was relevant that maybe would be an asset that we could use with the municipalities to kind of help them plan and think through that.
Not specific to any age group per se. I mean, Marissa, can you think of any program that we have specifically for that, for the elder geriatric patient? Not that I'm aware of.
Just connecting them with geriatric physicians?
Probably.
Okay,
yeah.
very good. All right, does anyone in the gallery?
Yeah, so
Yes,
your work with the Navy, I know that Duval County actually has the largest military retirement community in the world. Do you work with the VA and setting up relationships and other outcomes out of your work with the Navy?
We do. We have the ability to do that, and actually we've had a lot of challenge, and Joey could probably answer this better than I can. We've been trying to become credentialed with the VA to allow, patients that can't readily access care within the VA system, to allow them to come out into the outpatient setting and see community physicians. That is available to them. We've had a heck of a time trying to get the VA to credential us, and why? That's a question mark in my mind. Have we made any headway with that, Joey? That you know? No. And it's a shame. I know they do allow that relationship with some outside practices, but I could tell you just from our standpoint, it's been challenging. That being said, the base had been a great referral source for us in the pain sector, in the interventional pain. But I believe they have a pain physician now on, at NAS Jax. And so those referrals don't seem to be happening as much as they used to be in the past.
Yeah, and I know for a fact that they're struggling with Gulf War syndrome and how it's affecting a lot of different neurological specialties.
Yeah.
They're having to outsource that, so it would be a great resource if they use it.
We have our arms wide open to NAS Jax, the military base, the VA. We'll say we would love to support them if they would have us.
Tony, they're working very closely with our friends over at the Chinese medicine.
Oh, yeah.
So maybe we can find out how they're able to work so closely with them and try to bridge a gap here.
Yeah.
That'd be great.
Des?
Yes.
So earlier in your presentation, you mentioned challenges with recruitment, and I'm from primarily the dental side, so I'm trying to kind of wrap my head around this. Are you facing challenges with hospital systems recruiting people right out of their residency programs, or is it a challenge in getting independent physicians to think about being independent physicians out of the gate? Like, what are you facing as far as, what's the benefit for these guys to go into the hospital system, aside from some of the things you mentioned? Are they getting paid more by being part of the hospital system versus going to work with an independent physician that's wanting to grow a group?
It's a little bit of both. It's challenging to make the physicians understand why they would want to be in private practice. Why do they want to work in the hospital? Because it's easy. It's easy, and yes, they are recruiting the physicians right out of residency or fellowship training. That's the easiest time to grab on to the physician because they don't know any better, and they're willing to probably take less money, and they don't have a patient panel like we do. So our practice has a certain value because of the patient panel that we have with us. So if, let's say, Baptist wanted to hire me, that cost proposition would be very different than hiring a fellow just coming right out of training. Can they pay more? Usually, yes. They have much deeper pockets than we do. The other thing is they can tap into ancillary income that we couldn't even dream of. So let's say a pain physician is hired by a hospital system, and any laboratory studies that are ordered, urine drug screens that are ordered, imaging that is ordered, DME that's ordered, physical therapy that's ordered, surgeries that are ordered, theoretically that web all can funnel back into the hospital system. So they could theoretically give that physician a fraction of that income that they would make and pay a massive salary because of it. Now, not a direct one-to-one because that's illegal, but they know the math and they know what a physician can create in a hospital setting. We can't do that. A lot of times, legally, we can't even do it. So the system is against us. We can't create ancillary income. We can't charge for labs and because we can't contract for it. We can't get contracted for imaging because it's either difficult or the amount that they would pay us is pennies. So the system is so rigged against the private physician, it's a shame.
Is
So
there-
from a dollars and cents standpoint, the analogy would be you've got an NFL budget on one aspect, and here we are trying to work with a Division III college budget and trying to recruit Trevor Lawrence. Where do you think Trevor Lawrence is going to go?
Fair.
That basically is what it comes down. And all the infrastructure that the NFL has and the ability for them to create the income around a Trevor Lawrence cannot compare to what, let's even say a Jacksonville Sharks, indoor football league. It's just so mismatched.
Is there a statistic that maybe you're aware of how many doctors that go into a hospital system post-residency come out into private practice?
That specific number I don't
Yeah.
know, but that early statistic that I showed you is under 32% now of younger physicians are private practice doctors, which is a staggering number.
Well, we just met with 4 hospitals and a municipality to hear about what the hospitals were experiencing. And I can tell you that in my mind, if I'm a graduating physician, right, and I either have to go apply at practices or I've got people coming after me to woo me, and that's, maybe I'm in Indiana and the job is in Jacksonville, so they're gonna go through hoops and bounds to get me temporary housing. They're gonna make my way easy. It's just a whole different mindset. So again, that's why we're so passionate about what you all are doing, and we really appreciate the resources that you provide.
Absolutely.
What other questions? So what we will say is this is, again, we want to be a resource for you. If you have major initiatives that you feel like we can help with, our door is always open. We will do as much as we can to help you meet your objectives as we possibly can. We know what you've shared with us. I didn't know this was the largest medical society in Florida and the oldest, right? There's a lot to be proud of in Duval County, and so we really appreciate that you guys are at the helm, making the way as easy as possible for physicians in the area.
I appreciate that. It's a labor of love.
Clearly. So, all right, thank you. At this time, we'll go ahead and move over
Thank you.
into